Good morning, everyone. So today we are discussing a very relevant topic, and I'm happy to take this topic because being a mother, I had many concerns when my baby was newborn. And then as a neonatologist, we and a pediatrician, we see this concerns from a newborn very frequently. So today I'll be discussing this common newborn concerns which we see routinely in our OPD. So this is a very common sight, a new mother and a father who has not held a baby anywhere, anytime before and holding a baby for the first time. So they'll be having so many concerns, they'll be having so many doubts and would be coming to our OPD distressed for any single thing which shows up in their baby which is not normal. So this is a common sight for us. They will be coming and asking what is wrong with my baby. Is he or she okay? So before everyone comes, we'll just do a short buzz for 2 to 3 minutes. We'll just discuss what are all the common concerns by which babies would be brought. We'll just write them up in next 2 to 3 minutes and then we'll proceed for the talk. So please tell what are all the concerns you usually see in a newborn. Excessive crying, excellent. So don't know whether it is normal, physiological, abnormal. Breathing pattern, yeah, there is a noisy breathing, or is this breathing pattern normal, abnormal? Excellent. Regurgitation of feeds. Baby is vomiting a lot of milk. This is a complaint of many parents. Abdominal distension, pet mein sounds, rashes, yeah. Right, there are multiple types of neonatal rashes, passing stools frequently. Is it diarrhea? What should I eat? What should the baby be given? So both concern of mother and baby. Yellowish discoloration, excellent. So many babies would be brought with a jaundice, yellowish discoloration. बच्चे का आंख पीला लग रहे, hypothermia, they might come with these in the OPD, right? So this is, I think, is a pandemic right now. Breastfeeding problems, not able to latch, not able to breastfeed, no adequate milk output. Okay, so what is the basic newborn care? There will be many questions regarding how to do the basic newborn care. So almost all we have covered all the important common newborn concerns which bring the babies to our OPDs. Now let us proceed to see how to identify them, how to manage them, and also the most important part of that, how to counsel and elevate the fear of the parents of the newborn. So I think in our first list also the first thing is the excessive cry. So this is a very common complaint where the parents come and tell कि बच्चा बहुत रो रहे. Is it normal or is it abnormal? So one thing we should understand is crying is a physiological process. It is how a baby interacts with the family. So as they don't speak, we should understand it is a physiological process. And here you can see the length of time of crying according to the age. Usually a 6 to 8 month old baby would cry 2 to 2.5 hours per day. So depending on this, there is usually the crying starts at 2 weeks, increases by around 2 to 3 months, and by 4 to 5 months, it subsides. There are physiological differences between the babies. Some babies would be high criers, some babies would be low criers, and that is the graph showing an average crier. So this is. And why this crying happens? Because when baby is in mother's womb, mother would be walking all along in the morning. She would be doing her work. So baby would be gently rocked in the amniotic fluid. So these rocking motions cause the baby to sleep in the morning times. And at night, mother is sleeping. It is a quiet environment. Baby wakes up and starts playing in the nights. And one more thing is there is no diurnal variation. Like there is no variation in between morning, night, intrauterine. So when they come outside, suddenly it is not, they cannot make this day-night pattern, sleep pattern. So it takes a time for this in utero transition to happen, it will take usually a time of 6 to 8 weeks. This should be explained to the family. And then no two babies are alike. There would be different cry patterns. And important thing is how to identify what is causing cry. Like babies, when they are hungry, they cry. When there is a discomfort from stools, urine, they cry. And many parents tell कि baby पोटी करने से पहले बहुत रो रहा, baby सुसु करने से पहले बहुत रो रहा. So what happens is baby will try to coordinate his bowel activity and learns that coordination. So before that, straining would cause this irritability and crying. So these are all the physiological responses. So unpleasant sensation of full bladder before passing urine, painful evacuation of stools, or mere soiling of the diaper with stools also cause this excessive crying. But whenever we are seeing family comes with excessive crying, we should always see for red flags. We should take a proper history. How is the pattern of sleep, and what are was it a sudden onset? Is it inconsolable? How is the pattern? So these are the few causes of common causes of cry in the babies. One is this colic, where they would be usually telling there are audible gurgling sounds, पेट में बहुत गुड करता है, फिर comfort with expulsion of gas, which might be a colic. And then if baby cries suddenly at night time, then we should always think of insect bite or strangulation, hair strangulation of the fingers can happen. So sudden onset crying will have its different etiologies. And then foreign bodies may cause sudden crying. And in rare cases, gastroesophageal reflux with arching of, usually they will have arching of back and other comorbidities also. They may cause excessive crying. In babies who have fever, along with nasal catarrh and all, we should think of infections, acute otitis media especially, along with URI. And then urinary tract infections with fever can cause excessive crying. And there are very rare causes like babies who are already had HIE, and then their innate irritability, cerebral irritability causes crying. And here I want to tell a small story. I had a baby who came to emergency when I was a junior resident, and parents came with just crying. It was around a 3 to 4 month old baby. So it was the only symptom. And then a baby had a history of dilated cardiomyopathy, which was at 2 to 3 months, diagnosed at 2 to 3 months of age. And then I was a bit worried because I could not get anything on history and examination. It was just a cry. And then I called up the cardio team, ki aisa baby is just crying, there is no other thing. And I just told them to sit, get a ECG done because cardio SR told me. And within next 5 minutes, the baby was on a bed. There were multiple people coming and doing multiple interventions on the kid. And then I realized that the ECG was showing a supraventricular tachycardia. It was a SVT. So whenever we are seeing a child with this excessive crying, we should always take a proper history and a good examination. These are all the crux for a diagnosis. And I have shared a crying baby fact sheet with you. I have shared a Google link with all the common newborn OPD concerns. So you can just refer to that fact sheet. What are all the evaluations to be done? So coming to one of the most important causes of excessive crying, colic. Here I'll tell a mother's narration which was sent to me. This was a message which I have received. Hi mom, baby is uncomfortable since yesterday night. In the day he passed stool and flatters and got relaxed. Then again since evening throughout night he is uncomfortable and doing this type of movement. The type of movement he is doing is flexing the thighs, legs, and face which is red face. So this is how he is doing. And again, not taking feed well, and his temperature is normal. So this is the question. What is it? Is it simple colic? or it is something else. And other thing is he's not able to sleep also, sleeping for some time, again awakening. Yesterday in day after passing stool, he slept for 3 hours. So this is a routine, typical history which would be given by parents ki aisa ho raha hai daily. So this is colic. Colic is a functional gastrointestinal disorder. This is the name FGID, which is given according to Rome criteria, which is a functional pain of the, initially there were multiple definitions to define colic. Like if the baby is having more than 3 hours cry in a day for more than 3 days in 3 weeks, then it is diagnosed as colic. But then the definition gradually got changed because it is difficult. 3 weeks is a longer time, that was reduced to 1 week. And then later, now, Rome 4 definition gives that it is a functional gastrointestinal disorder which does not have any anatomical or a inflammatory problem, where there would be excessive cry as perceived by the parents. So this is how colic is defined now. And coming to the pathophysiology, why it happens, this is a distinct clinical entity, but the pathophysiology is still unclear. Like there are multiple theories which were there to explain the colic, some of them being there are multiple maternal factors, maternal stress, depression, family condition, and then baby factors, which are again gastrointestinal factors and non-gastrointestinal factors, like lactose intolerance, immature enteric nervous system, which causes increased sensitivity to pain, motilin receptor immaturity, and then lactase deficiency, sometimes cow milk allergy, altered gut microbiome. So as there is no single pathophysiology which is demonstrated, there are multiple theories. As we know, if there is no single cause identified, it would be a multifactorial thing. And then among these, lactase deficiency and altered gut microbiome, these are being evaluated recently in many trials and are showing more promising results. But as of now, we do not have a clear identified pathophysiology. So this is a diagnosis of exclusion now. And for this, for any diagnosis of exclusion, we should have a careful clinical history and examination, which should be done prior to coming to the diagnosis. And at the same time, it is not necessary to do all the investigations, like starting from CBC to ultrasound abdomen to whatnot. But it should be more of a practical approach, where clinically we should see, and with examination we should be able to plan the investigations. So management, as there is multifactorial etiology, management also would be, there would be many options. But the key thing which is told to be parents is reassurance. Colic is a norm, it resolves by itself. This is what should be told to parents. By 2 to 3 months of age, usually it resolves. This reassurance should be always given to parents. And then sensitive differential responding. Parents should respond sensitively to the baby's cry. For example, like taking the baby close to the parent, placing on a prone position, helping to expel the gas from both from the mouth and from the below, and then taking the baby for a drive, a gentle music. So these are all soothing. These are all the things which soothe the baby. So these are to be told. And antispasmodic drops, herbal or probiotic supplements, all these have no convincing evidence as of now. And as I told, lactase and altered gut myobiome. So there is multiple research going on. So lactase drops and probiotic drops are also coming. So I need volunteers to. This is a very frequent medicine which is used for babies. Colic drops. Everyone would be asking, Janam Gutti de sakte hai, gripe water de sakte hai. So before telling them, we should know what are the ingredients in them and are they useful or not. So I need volunteers to tell about each of them. Regarding gripe water, any idea what is there in gripe water? So gripe water, it contains herbs like dill seed and all. It also contains alcohol, sugar, and soda bicarb. So these are all the ingredients of gripe water. Now they are coming even as sugar-free, alcohol-free gripe waters. But we should note that it contains soda bicarb, which might cause metabolic alkalosis. Soda bicarb is basically to मतलब जो गैस है उसको HCl को न्यूट्रलाइज करने के लिए it is tried. And then Kolicaid, content of Kolicaid, mechanism of action, we write for every baby, Kolicaid drops. So it contains simethicone, an interesting compound. What simethicone does is, it is a anti-surfactant basically. So it reduces the surface tension. It turns larger gas bubbles into smaller bubbles so that the flatus can be passed easily by the baby. And also it prevents formation of new gas bubbles. Whenever digestion happens, there will be multiple gases which would be formed because of hydrogen coming from the food gets digested. So simethicone reduces the formation of these gas bubbles and also it makes them into smaller bubbles so that baby can pass. And then Janam Gutti. This is a question which we hear daily. Baby ko Janam Gutti pila sakte hai? So Janam Gutti contains many herbal preparations like ashwagandha and other things. But as we can see here, double one thing, honey, there is with honey. We can see there. So honey is contraindicated in babies. WHO recommends honey should not be given in babies less than 1 year of age. So this is about Janam Gutti. And then these are the new trend which is coming now, Yamo drops, which are lactase drops. Still, they are with the medical representatives. They will be distributing to us in a short time. And then this is Dr. Reddy's lab made Lactobacillus reuteri, which is a probiotic and claimed to have benefit in kids with colic. And then cyclopam drops, which is rarely used, but we should know that cyclopam dicyclomin should not be given in infants because it has serious side effects like delirium. It can also cause seizures and all. So cyclopam drops are one thing. So all these come as colic drops. So we should be cautious. We should be knowing what is there in the drops and what are all the side effects of them. And colic is by itself, it will go by next 2 to 3 months. So we should keep it in mind before advising all these type of medications. Fine. Coming to, I think, the next problem which we have shortlisted, posseting, that is vomiting after feeds. So this is this picture, as you can see, if the baby vomits a small amount of vomit, parents see as if how the baby is vomiting there. So there will be a lot of concern regarding this posseting or vomiting. Why it happens is there would be swallowing of air which happens during feeding and also transient relaxation of lower esophageal sphincter which happens that causes regurgitation of feed which causes this posseting. And reassuring feature should be adequate weight gain. In cases of posseting, though the baby is vomiting, there would be adequate weight gain. And investigation should be done only if there are red flags. Like if the vomiting, the questions we should be asked is if it is a projectile or a non-projectile vomiting, if there is any bilious bile stain, or there is an abdominal distension, or any other symptoms like poor weight gain associated with this vomiting. Only if these are there, it should be investigated. In case of rare causes, if it is along with these conditions, the hypertrophic pyloric stenosis, and then raised ICP, systemic infections, some rare causes like metabolic disorders, and then salt-wasting congenital adrenal hyperplasia. These are all the pathological causes which we should keep in mind when baby comes with vomiting and with the, if there is underlying things on examination. One important thing we should understand is the difference between gastroesophageal reflux and gastroesophageal reflux disease. GER versus GERD. Gastroesophageal reflux is a normal physiological response where is a normal physiological thing where there would be no weight loss, no respiratory symptoms, no symptoms of esophagitis like excessive crying, and there would be no neurobehavioral symptoms like Sandifer symptom with abnormal neck hyperextension, torticollis and all. So if it is only GER without any symptoms, then reassurance are techniques like burping, because it is due to aerophagy and all, burping should be advised, and physiological, it would decrease physiologically at around 6 to 8 months. And if there are these symptoms, then the evaluation for GERD, gas reflux disease, should be done. So there is a nice IAP standard treatment guidelines which have come. So there is a IAP STG for GERD also, which you can look up. And next thing I think we have listed, one is feeding issues. So this is a very dear topic to me because this is my own story. I think as at present, feeding issues are a very important concern for all the parents. I feel initially they used to have multiple babies. One mother used to have 4 or 5 babies, and then grandmothers, great-grandmothers, they all used to be along with the new mother. So they used to give the lactational support, lactational counseling, which used to be needed for the baby. But now, in our current scenario, this is all a nuclear family. Mother would be there, grandmother would be there, but they also are not very confident of the technique. So this is causing a lot of feeding problems, feeding issues nowadays. So this is my story. My being a pediatrician, a neonatologist, was a 37-weeker baby, 2.5 kg, and then had very difficult attachment, latching, and I needed lactational support up to 3 months, 3 to 4 months I needed a lactational support. So these are some of the common feeding issues which are there. That is a primary mother, usually anxious, no antenatal preparation. In many of the cases, there will be no antenatal preparation. And then worry, lack of confidence, which is aggravated by poor milk output. In initial 2 to 3 days, there will be only colostrum coming, and then they would be anxious. This might be causes. So for primary mother, a sympathetic advice, encouragement, moral support, and then teaching the technique of breastfeeding and adequate hydration to the mother are important things in case of a primary mother. And then there are few conditions which are mechanical. For example, there might be a retracted nipple, a flat nipple, and breast engorgement, which makes the baby difficult to grab onto the breast. And then in case of preterm babies, there would be incoordinate suck and swallowing. So in these cases, what should be done is syringing technique helps in cases of retracted nipples, and proper attachment should be ensured. And then there are other set of problems like sore nipples and painful nipples, cracks and breast engorgement. So in this, the most common reasons are like frequent washing of the nipples with soap and water, or forceful delatching, and sucking onto nipples instead of the breast, bottle feeding. They all cause these problems of the sore nipples. So in these cases, continuation of breastfeeding with proper analgesia to the mother, along with a proper technique and emollient or hind milk application will be required. So I want to just elaborate a small scoring system, a LAT score. to see which component of breastfeeding is affected. Like, is the positioning affected, latching affected, or what is the problem? So it has, as the name tells, LATCH. It is, L is latch. Is the baby latching or is too sleepy? Or latching, grasping the breast, tongue down, lips flanked, rhythmic sucking. This is what we see for the effective latch, right? 4 things to see in a proper attachment. We see for the latch. And then audible swallowing. Is there any audible swallowing which is heard? And then type of nipple, whether it is an inverted nipple, flat nipple, or a everted nipple. And then comfort. How is the breast? Like engorged, cracked nipples, bleeding, large blisters with severe discomfort, or it is soft or non-tender. And then positioning. How is the baby held? Is the baby held with support, like someone comes and have to hold the baby, or baby should be held first, started latching, and then mother can take over, or there is no assist, mother is able to position or hold himself or herself. So these are the things, this score gives a comprehensive idea कि अगर फीडिंग डिफिकल्टी के साथ मदर आई है तो कौन सी डोमेन में उनको डिफिकल्टी है, पोजीशनिंग में डिफिकल्टी है, लैचिंग में डिफिकल्टी है, या कंफर्ट में डिफिकल्टी है, एंड देन सो दैट वी कैन गिव अ प्रॉपर एडवाइस रिगार्डिंग द डिफिकल्टी विच वी हैव identified. So in my case it used to be the whole difficulty, and for first 2 to 3 months I required a minimal assist, and then I used to take over. So accordingly I was given lactational counseling. So this is how to do and how to approach in case of feeding problems. So we should always understand that breastfeeding is not just a passive ritual. It is a bonding between a mother and a baby, where the baby cuddles to the mother, and it's an art. So proper positioning and attachment are the keys for its success. And even for breastfeeding, in difficulties in breastfeeding and most frequently asked questions, we have a IEP standard treatment guideline where which you can go through, like all the questions कि अगर वर्किंग मदर है तो क्या करना है, कितने देर दूध को बाहर रख सकते हैं, how to do, what to eat, what not, all the things are there in this IAP STG. You can go through that. Coming to few transplacental hormone disorders where baby has the hormones from mom goes to the babies, which are like mastitis neonatalum, where the baby will have enlargement of breast because of inactivation of progesterone estrogen after birth due to immaturity of neonatal liver, and then vaginal bleeding, where 1/4 of the newborn female girls usually have because of withdrawal of hormones, and then mucoid vaginal secretions, which are just too gently to be cleaned at the time of birth. These are all normal transplacental because of transplacental hormone disorders, so they're not to be worried about. And coming to one more common thing is superficial skin lesions, rashes, which we have elaborated, which we have taught. So majority, like infections are caused by gram-positive organisms like pyoderma, and then there are things like conjunctivitis, umbilical sepsis, diaper rash, oral thrush, which happens. So a few common superficial skin infections like pyoderma, where there are pustules which would be seen in scalp, neck, groin, and axilla, which can be managed with local antibiotics, and daily examination should be done to see for any spread. Whereas in case of systemic spread, we can give antibiotics, oral or parenteral. And then umbilical sepsis, many parents have a doubt regarding umbilical cord, that there is a slimy discharge, there is a whitish discharge which is coming from the umbilical cord. So this should not be mistaken for sepsis. If there is redness, erythema, induration, pus discharge, then it is called umbilical sepsis. Usually when you are telling umbilical cord care to the parents, tell that the diaper or the cloth should not cover the umbilicus. it should be below the umbilical cord area so that it will not touch and cause irritation to the area and then discharge. And then and it should be kept dry. If there is mild cases of purulent discharge or redness, cleaning with alcohol and application of antibiotic powder would be enough. But if there is a induration and systemic signs, then IV antibiotics should be started. Coming to oral thrush or candidal diaper rash. Diaper rash we would be discussing in detail in next few slides. But if it is a candidal diaper rash or thrush, which is usually because of infected feeding bottles, also prolonged antibiotics, then the treatment would be local application of the antifungals 1% clotrimazole or miconazole, etc. And in refractory cases, we can also go for oral fluconazole treatment for 2 weeks. And now the next common thing कि बेबी 3 दिन से पोटी नहीं कर रहा, ये ठीक है या नहीं, या बेबी हर फीड के बाद पोटी कर रहा, मुझे लगता है कि बेबी को दस्त हो गया. So this is a one common complaint which we hear from the parents. So constipation is this, my baby has not done poo for several days. Then what we should think is usually cow milk and formula feeds, they form hard casein curds, which would be difficult to be evacuated. So in those babies, there would be features of this constipation. And then in cases of breastfeeding baby, we all know that stool frequency is quite variable. Like a baby can pass after every feed, that is 8 to 10 days per day, or baby can even pass after a week. This is physiological and it is normal in breastfeeding babies. So some signs of straining before passing stools, as we have discussed, it is because of learning of coordination. It is normal. Laxatives are to be avoided. If in cases of refractory cases, along with other symptoms like abdominal distension or there is like abdominal distension, we should see in refractory cases for conditions like Hirschsprung disease, where there would be with rectal stimulation, there would be sudden passage of stool, and then anal stenosis. And we should always look for features of cretinism or hypothyroidism is to be ruled out. Coming to the so-called diarrhea which the parents perceive, it is because of gastrocolic reflex, baby passes stool after every feed. That is to be explained to the parents. And then, but here we should always be careful. Like if it is a daily routine that baby is passing after every feed, it is fine. But if there is a change in stool frequency, like initial till 1 day prior baby used to like pass 3 to 4 times a day, and there is a sudden change in frequency, sudden change in consistency, along with other symptoms, we should always take a careful history and see if it is an infective diarrhea. We should also keep in mind that maternal drugs, maternal food, maternal drugs also have an effect on the baby's stool. And then in cases where it is pathological, if we suspect infective diarrheas, congenital thyrotoxicosis and some rare metabolic causes can also be a cause of this increased frequency of stools. Coming to umbilical granuloma. So not very common, but frequently we see this in the OPD, that baby is having a mass in his or her belly button. So this is, sorry, I don't have a pointer. So this is how the mass looks. Thank you. So this is how the mass looks. Here we can see there is a small flesh-like pale nodule at the base of umbilicus with a discharge. So this is called umbilical granuloma. What has to be done is a common salt, application of just a common salt which is available can be used to treat this condition, or silver nitrate is also a cautery which can be used to treat this. So application of common salt on the lesion for 1 to 3 days along with and then seeing for response. And then the course can be repeated after every 3 to 4 days for a few days till the granuloma resolves. So in this baby, we can see here, baby was given treatment like common salt for 3 to 4 days, and within next 1 week, the granuloma has, which is there here, it has disappeared. So if there is a discharge, then or if we suspect infection, T-Bact ointment, antibiotic ointment local application can also be done if there is infection. And one more thing which usually brings parents is बच्चे को बहुत आंख से पानी आ रहे, ये normal है, इसको infection हो गया या क्या हो गया. So we know it is an obstructed nasolacrimal duct. In this cases, we should be knowing how to counsel the parents, like how to teach them the technique of massage. So it is because of blocking of nasolacrimal duct, and treatment would be pressing the lacrimal sac area and massaging nasolacrimal duct. So just keep in mind where the nasolacrimal duct starts from and it ends, and massage the area at least 15 to 20 times per each time, at least twice or thrice a day. And this is how inward pressure from above downwards along the lateral margin of the nose. This is how the technique is to be explained. And it is also a physiological condition. Usually the block clears in first 1-2 months, and then usually it disappears. And coming to cradle cap, seborrheic dermatitis, we are confused. क्या एडवाइस देना है, कौन सी शैम्पू लिखना है, कौन सी क्रीम लिखना है, क्या करना है. So this is what to do with this dirt and flakes. Seborrheic dermatitis, as the name itself is telling, it is dermatitis. It is a chronic inflammatory condition of the seborrheic area. Seborrheic area is the area which involves the sebum glands, which involves the face, axilla, gluteal folds, groin area. So all these areas can be involved in this seborrheic dermatitis. It is not only the scalp, it may involve other areas like face and diaper area also. It usually starts in first 3 to 4 months, and then spontaneous recovery takes place at around 6 to 7 months of life. Here also, like our colic etiology is unclear. There are multiple theories, malassezia, furfure causes, but it is not always present in all cases of seborrheic dermatitis. And then abnormal hormone, transplacental hormone might have caused, or abnormal host response, as it is an inflammatory disease. Abnormal host response is also thought to be an etiology for this seborrheic dermatitis. And one thing we should keep in mind when we are treating these children is we should always have in mind the other differential diagnosis. Like atopic dermatitis can also present with this kind of rash in a rare cases. But in those babies, there would be weeping lesions, usually red lesions, weeping lesions, where we can differentiate between seborrheic dermatitis and atopy. And a very simple thing, which is a treatment for this is, it is a physiological, it is almost like a physiological condition. So application of coconut oil or any Vaseline or any emollient, even in Meherban Singh sir tells that on top of the milk there would be scum. So even that can be applied on scalp at night. These are all the, they are to smoothen the crusts. So basic thing is we have to smoothen the crust and then remove them slowly. A soft comb can be used to remove them, and a mild shampoo is to be used twice or thrice a day. This is the basic treatment. If it is not responding in refractory cases, if it is very disturbing, involving other face and other areas, then we can use mild topical steroids like 1% hydrocortisone. And shampoos like 2% ketoconazole can also be used. But we should always keep in mind that these shampoos they are irritant and they cause irritation to newborn eyes. So considering that it responds by 5 to 6 months of age, it usually disappears by itself. We should always think of the benefits and harms, and then we should start the treatment. So if you just Google cradle cap products, these are all the products which we can see on our system. So many products are available online, but basic thing what they'll do is there are scalp creams which are moisturizer creams like Vaseline or coconut oil, and then there are multiple types of combs available, and then gentle baby shampoos. Some contain keratolytics like salicylate, which help in removing the dirt and flakes. Some contain ketoconazole and all. So these are all the things, but we should know what is the etiology, pathogenesis, how it is going to progress, and how to treat it. And coming to another important problem, the diaper rash. So this is, I think the image is not very clear, but we know all of us have seen diaper rashes, many. So we should have a rational approach when we are proceeding for a diaper rash evaluation and management. So the main cause of diaper dermatitis, there are multiple types of dermatitis. One can be irritant contact dermatitis because of contact with feces and urine. They are not being cleaned regularly. That causes irritation, so causes irritant contact dermatitis. Other causes can be like candidal dermatitis, seborrheic dermatitis. These are all the other causes of dermatitis. So whenever we are seeing a case of diaper rash, we should be able to identify which type of dermatitis it is. Usually the delay in changing diapers causes redness, induration, excretion. And then the treatment would be, as it is a irritant dermatitis, try to remove the irritant. That is diaper-free time, frequent cleaning of stools and urine as far as the baby passes. And then we can also use soothening ointments. So हम सबको पता है, we have written a lot of soothening ointments. But what we should understand is, these soothening ointments are actually barrier creams. They are barrier. Contact हो रहे ना, contact के वजह से it is causing irritation and then dermatitis, right? So to prevent that contact, they act as a barrier between the baby's skin and the irritants. So whenever we are applying them, they should be applied like barriers. मतलब जैसा केक के ऊपर हम आइसिंग करते हैं ना, जैसी केक we take a cake and then पूरा आइसिंग completely covering the cake. It should be like that, the application. Should be like icing over the cake so that stools will not come in contact with the skin. And then it gives time for the skin to heal. And the best thing is, as we know, prevention is better than cure. Preventing diaper dermatitis. Though it is very easy to tell कि diaper नहीं पहनाना, but in winter seasons and when baby passes urine and stool frequently, parents might prefer using diapers. Then one option is they can apply the barrier cream and then use the diaper, and frequently changing the diapers whenever the baby passes urine and stool can be advised. And in cases when there is rash which is having erythematous papules with satellite lesions, like away from the rash also there will be small lesions if they are present, or if the rash is involving fold areas also, groin fold areas also, then we should be thinking about other causes like candidal dermatitis, and in those cases antifungal should be used. And there are also few minor developmental peculiarities which are special to newborns, like the rashes, which you have told there are multiple skin rashes parents come. So acne neonatorum is one of them, comedones over forehead, nose, cheeks due to transplacental passage of maternal hormones. And then milia, these are yellowish white spots on nose due to retention of sebum, which may present as rashes. Most of these rashes will resolve spontaneously. Nothing is to be done in these cases. And few parents come complaining of tongue tie, and all the guilt is onto the tongue tie कि बच्चा feed नहीं ले रहा, latch नहीं कर रहा, शायद इसको tongue tie है. But most it doesn't usually cause. Tongue tie is a form of thin membrane or thick fibrous frenulum producing a notch at the tip of the tongue. Usually it will not cause feeding problems. It can be snipped off after 1 year of age if it is really concerning. And one more developmental peculiarity is umbilical hernia, which parents do notice, which is undergoes spontaneous resolution by 6 months to 1 year of age. And surgical closure is indicated only if it persists to up to 3 to 4 years of life. And associated conditions like increased intra-abdominal pressure, excessive crying, constipation, persistent cough always should be looked into. And one more favorite topic, that is, I think Animesh has pointed, baby's eyes are looking yellow. So this is a baby who was bought at 1 month of life. That yellowish discoloration of eyes notice किया हमने day 8 of life से, तब से इसको जब भी हम धूप दिखाते हैं तो ठीक हो जाती है, फिर दोबारा ये पीला लगने लगती है. तो what is the problem with the kid? And she does not have any clay colored stools, and there was no history of blood transfusion also. So whenever prolonged neonatal jaundice is if the jaundice persists for more than 2 weeks in a term baby or more than 3 weeks in a preterm baby, and this always history and examination is very important. History will start with the what is the color of the urine, what is the color of the stool, so that we'll understand whether it is a conjugated jaundice or a unconjugated jaundice. And then how is the clinical status of the baby? Baby is active, feeding, gaining weight or not, because to differentiate a sick baby from a normal growing baby. And any history of consanguinity, other previous sibling affected or a family history to see for hemolytic anemias. And then general examination to note for well-being, growth pattern, tone, cry, activity. Here it is always important to look for the color of urine and stool by ourselves. If it is not there, we should ask the parents to bring photograph of the stool to see the color of the stool. And then extent of jaundice, pallor, rash, hepatosplenomegaly, dysmorphism for Alagille syndrome. These are all to be seen in examination. And when examining systematically, we should look for underlying causes like cephalhematoma, presence of cataract, for torch infections or galactosemia, see for midline defects to see hypothyroidism, and also hepatosplenomegaly. So in these cases, initial investigation done is total serum bilirubin and then direct fraction. Depending upon the type of jaundice, we further proceed for the first line investigations. So in case of unconjugated jaundice, the first line investigations would be a complete blood count along with a reticulocyte count and a peripheral smear with a DCT to see for hemolytic causes. And then T3, T4, TSH should be done to look for hypothyroidism. G6PD levels to see for galactose-6-phosphate dehydrogenase deficiency. Urine routine and culture to see if the baby is having UTI. And urine for reducing substances for galactosemia. So these are first line investigations which are to be performed if the baby has unconjugated jaundice. Depending upon the reports and baby condition, we can go on to the further investigations. Whereas in case of a baby with conjugated jaundice, we should be doing CBC, CRP, blood culture to look for sepsis, and then LFT with AST and ALT to see for hepatitis. PTINR, synthetic functions of liver, GGT, TFT, and urine to see for hypothyroidism, UTI, and galactosemia. And coming to one more thing, that is noisy breathing. So this is a message from a friend or from from all the parents we usually get, that the baby is taking breathing discomfort, sometimes particularly after feed, with suprasternal retractions also, gadde bhi pad rahe. So in these cases, we should see for onset, duration, pattern, any other symptoms. Are there any significant antenatal or postnatal events and any other associated features? So we should understand that many of these conditions which happen in a newborn baby are physiological, and we should be able to differentiate whether it is a physiological or a pathological condition. So we should know how the physiological conditions evolve, what is their natural history, and how to see them. So basically, first we should have a knowledge of all these things, and then careful history and examination. A mother or a family can notice every change in a baby. So never ignore the symptoms which they are telling. Always take a careful history and do a good examination to see for findings. And then management of specific condition if it is diagnosed, or many of these conditions need just your parent assurance of the parents, which should be done in a. These are some of the learning resources. One is Meherban Singh Care of the Newborn textbook, which gives comprehensively about all these conditions. And there are WHO recommendations on maternal and newborn care for positive postnatal experience, which is given by WHO. And importantly, we have a National Neonatology Forum. You can see NNF, our National Neonatology Forum, has clinical practice guidelines, covers most of the topics, most of the problems of the newborn babies. NNF CPG, which are available free online, where you can get all the learning resources for this newborn conditions. And I have also shared a handout for today's presentation with you. That is common newborn concerns karke I have shared to all. If it is not there in your mail, just check the spam folder, because I have sent it as a bulk, so it has gone into spam folder in some of your mails. You can just check out your spam folder. Many of the topics I tried to cover in it. These are the learning resources. Thank you.